Very happy to see all of you here. We are going to talk about a very, very important topic today, methylation. I think in post, it has always been an important topic, which we allopathy doctors have been trying to put under the carpet for so many years. But I think now post-COVID times, this is the need of the day that we start addressing it, talking about it, helping our patients, setting it right, so that we can, lead a healthy life. The topic is good and the presenter is super amazing. I love listening to Tracy's videos, especially I love the way she goes to the very basic of science. And she makes it so simple that, when I'm walking or I'm very relaxed and I want to just hear something which will add to my knowledge but not stress me, Tracy is the person I go to, right? Because I've done my fellowship from A4M, Tracy, and those are like very intense courses, and then you have to go and dig deep down to make sense of the whole thing. And on the contrary, yours is very simple, very nice, very to the point and deep. So I'm very, very excited, and I think all of us are. Without wasting any time, I invite you, Tracy, to share your thoughts on methylation, facts, myths, and what is it that we can do and how can we manage it nicely, properly, scientifically in the present times. So welcome, Tracy, and the floor is yours. I know you appreciate questions in between also, so if there is something urgent and connected, I will, nudge you in between and request you to answer it there. But otherwise, we will take most of the questions in the end so that your flow is not broken. Right?
Okay, very good.
Welcome, and the floor is yours.
Thank you, Dr. Priti, and everyone who is gathered today. Thank you for the privilege of presenting to your community. And I want to begin by saying thank you to all of you for your progressive drive to understand functional medicine. And as Dr. Priti well said, I think these pandemic days have increased the demand for that in terms of understanding on a more detailed level what is actually causing and what we can do on a day-over-day basis to alleviate, in particular, long COVID type of dynamics, which I fear is going to become a separate epidemic on its own. But I will share my screen here as Dr. Priti said, I am passionate about functional medicine. I am the founder and lead instructor at the School of Applied Functional Medicine, and we teach a rich diversity of healthcare practitioners to apply functional medicine science. The esoteric science of functional medicine can be fascinating, but as Dr. Priti well said, it can be overwhelming and can distract us from the work of how do we actually support patients to get better. And so the topic of today is methylation. And I want to begin by actually quickly setting the stage for methylation. But I want to spend a bit of time talking about the modern world, the modern lifestyle demand for methylation, because so much of our opportunity, I believe, as practitioners is not just to boost methylation and stimulate more activity in the enzymes that support it, but to reduce the demand for this biochemical process so that our bodies are less likely to become overloaded. I will briefly speak to the notion of redox imbalance, that is antioxidant and pro-oxidant function in the body, because it's actually important that we have both. Very brief overview of methylation, as I'm sure you're all quite familiar with the biochemical conversions. I do want to spend a bit of time on the transsulfuration process and its ultimate outcome, which is glutathione, because I believe that especially in the pandemic time, so much of this impaired methylation and this elevated homocysteine that many of you are seeing is simply because there is too much oxidative stress. There's too much oxidative damage, which is impairing the function of enzymes that drive methylation and putting too much demand on glutathione availability. And we end up stuck. We end up with a biochemical impasse in the middle of those. I will share with you some information about nutrient considerations for methylation. As I was sharing with Dr. Priti earlier, I prefer to give you a rich, lengthy slide deck so that you have plenty of information for later reference, including some hyperlinks to published research, but I will not be speaking to every slide in detail, but I'm happy to answer questions you might have about it. And I want to be sure that we get to a related but larger topic of COVID considerations and what research to date is making quite clear is at play in long haul COVID dynamics and also post-vaccine, especially post-mRNA vaccine disease dynamics. But without further ado, I want to briefly set the stage for methylation. We're all well familiar with functional medicine and the necessity of looking at the overall system in which an organism is functioning. We would never try to diagnose, treat, or regress disease in a leaf on a plant, for example, without also considering the health and function of the stem, the stalk, the branch, the trunk, the roots, the soil, the air, the environment, the neighbors, all of the different things that are at play. And everything is interconnected in the realm of functional medicine. And this can be a challenge to all practitioners because we are looking for the quick solution. Pharmaceuticals have taught us to look for the pill for the ill, if you will, and a quick fix. But if functional medicine teaches us anything, it must be patience, because it is not logical to expect the regression or the remission of a disease dynamic unless we go upstream and address the root causes and mediators of that disease. We can use a pill, we can use a drug, a supplement, a food in order to provide relief or maybe to manage the negative effects. But we must persist and look further upstream at what in a unique person's life system is causing or driving a certain dysfunction so that we can step-by-step address it and therefore logically expect sustainable improvements in health. Otherwise, what we will see, of course, is perpetual recurrence of disease dynamics. In terms of functional medicine and delving a bit into the specifics of methylation, we know that there are indeed many interconnected life choices, genetic dynamics, and also interactive biochemical systems that affect ultimately whether a patient feels well or feels ill. And we must, of course, always remember that these factors are not isolated. As much as we might focus on the power of genes, and there are many genes in the realm of methylation that express enzymes that affect this biochemical process. Most of us are well familiar, for example, with MTHFR, which is what I call the celebrity gene in the realm of methylation. But we must not lose sight that there are many other genes and enzymes, dozens of them, that affect methylation, even dozens that affect the behavior of folate. And so we want to avoid the trap of over-focusing on any one single genetic variant and assuming it is diagnostic of a need for, say, a high-dose supplement. A good example of this is that an individual, say, could be homozygous for the C677T variant of the MTHFR gene, which impairs the body's ability to methylate folate and bring it to the methylation process. However, a person could have this variant that we believe is the most extreme impairment of that enzyme, theoretically. But an individual who has that genetic variant may have a homocysteine of 30, of great concern, and maybe be prone to atherosclerosis as a result of that. Or a person with that same genetic variant may have an ideal homocysteine of 6 and not be struggling at all. And it's a good reminder that just because we have the gene does not mean that that gene is active. And so genetic data can be valuable, but it is not sufficient for determining interventions. And I believe we should always focus more on greeting the patient where they actually are and using genetic data as a secondary or tertiary set of information to look at, say, what a person might need to sustain improvement after we actually assess and address what their body is literally experiencing right now. We must, of course, consider the effect of other interconnected biochemical or physiological systems, and then the effect of biochemistry from a nutrient viewpoint. Digestion is something that is often forgotten in functional medicine, and the necessity of having good digestion and nutrient absorption to support methylation. The widespread prevalence of acid reflux and utilization of proton pump inhibitor and H2 receptor blocker medications that are purposefully suppressing stomach acid. And we need good, strong stomach acid in order to enable strong binding between vitamin B12 and intrinsic factor as the nutrient leaves the gastric cavity to ensure its sufficient uptake later, further down in the ileum in the small intestines. People who are using acid suppressing medications are very likely to struggle with optimal levels of vitamin B12. They may be normal levels, but as we well know through the functional lens, they may not be optimal functional levels. This is a good reminder in casting a broad net and looking at which of your patients are logically likely to struggle with methylation optimization. And we must go upstream and look at nutrient availability. Individuals in your practice are more likely, even than in the American community, to be choosing a vegetarian or a vegan diet. And these individuals are necessarily going to be more challenged to bring bioavailable B12 into their bodies, much less to digest it, absorb it, and make it readily available. The same is true in the days of COVID, because anywhere where there is a high density of ACE2 receptors, which is where we know the SARS-CoV-2 virus docks and the immune battle takes place, there is likely to be quite a bit of oxidative damage to that tissue. And a strong factor in long COVID is oxidative damage to the intestinal lining, the small intestinal lining, where there is a very high density of ACE2 receptors. And this can be impairing the body's ability to bring on board B vitamins, not just B12, but folate, B9, B6, and also notably amino acids such as tryptophan, in order to support the body's serotonin function, which is needed to make melatonin so that people can sleep well. And there is no way to heal from post-infectious disease if you are not sleeping deeply and consistently and at length. And so there's an interconnectedness here that we must consider. Melatonin essential as a neurotransmitter and a hormone. Serotonin is its precursor, and we must methylate serotonin in order to make melatonin. But COVID has also reminded us of the essential nature of melatonin as an antioxidant. And you may not naturally think about the necessity of melatonin for healing damage to the endothelial lining of blood vessels. especially of arteries on the other side of COVID. Again, a place where there are many receptors that have been damaged, and the endothelial function can easily lead to hypertension and other downstream cardiovascular disease. And yes, we need nitric oxide. Yes, we need glutathione for this healing, but we need melatonin. Melatonin is critical cardiovascular antioxidant. For immune function, when we are generating histamine from our immune cells in order to counter any infection, of course, we degrade that histamine using methylation. In the gut and in other mucosa, we use diamine oxidase to degrade histamine. But intracellular histamine must be dealt with via methylation. And this can be a reason why individuals struggle with the buildup and challenges with excessive histamine that, yes, can lead to nasal respiratory congestion and postnasal drip and trouble with breathing. But also excessive histamine can lead to other issues such as anxiety and ongoing headache. These are common dynamics in individuals who have COVID disease or long haul COVID. And so we must methylate to support immune resolution. Many people with COVID are struggling with aggressive immune function, which sounds like a good thing on its own, but not if it is not being well resolved. We need good balanced immune function where pro-inflammatory and anti-inflammatory function are balanced and inflammation is resolved quickly. This speaks to the role of other key supportive nutrients like essential omega-3 fats, EPA and DHA, and their metabolites, which are part of inflammatory resolving function in order to ensure that appropriate inflammation to counter infection is also not allowed to wreak excessive oxidative havoc on the body in the process of fighting an infection. Metabolism, the process of generating energy. We all know that our communities struggle with epidemics of insulin resistance and diabetes, and this elevated blood sugar does damage to all sorts of different tissues. This is where we need potent glutathione function. And perhaps the most important downstream product from methylation is glutathione. And so to protect our bodies from the effects of elevated blood sugar, we must methylate well. Methylation is a phase 2 detoxification process that helps us to deal with toxins such as endocrine disrupting chemicals that are widely present in our foods, our personal hygiene and beauty products, but also to handle biotransformation and clearance of endogenous toxins or potentially toxic substances like estrogen. We are living in modern times where so many chemicals in our life system potentiate the effects of hormones, especially estrogen. And we need to methylate in order to metabolize estrogen into its less estrogenic and less carcinogenic forms, the methoxy estrogen metabolites. This helps us to be less vulnerable to imbalances in endocrine effects. And of course, we see in our communities now young women reaching menarche at earlier and earlier ages. We have epidemics of estrogen-mediated dysfunction, whether it is polycystic ovarian syndrome or infertility due to imbalanced hormones, highly debilitating premenstrual syndrome or heavy menstrual bleeding and clotting that furthers challenges we already have with iron deficiency and anemia. Methylation is central to these balances. And so just a brief introduction of so many different factors that methylation is dependent upon. And this brings us to the importance of understanding the critical functional balances that we must maintain. And an imbalance in these key aspects of health is likely to increase the demand on methylation. Now, I do want to speak to a reality that we see in our practices all the time, and Dr. Pretty well queued this up, that so often the people in our practices who are struggling with multifactorial disease, the body is actually working exactly as it was designed to work. What we are seeing is a disconnect between the choices that patients are making. They're living in the modern world with all of its social and cultural aspects and priorities. And many people we support are living lives where their choices are leading to bodies that are stressed and toxic, low grade, or maybe even high grade, simmering inflammation, infectious dynamics, maybe many calories, but not a lot of nutrients. We don't prioritize sleep. We sleep just enough to get by. And these are common cultural choices, but the body is reacting to these choices and creating a life experience that is not what most people want to be living. Most people want to be thriving and relaxed, and to experience good fertility and easy pregnancy and reproduction. They want to be lean. They want to feel well with high vitality and heal quickly. And when we are making life choices that promote, in particular, a sympathetic dominant nervous system mode, it would be unnatural for us to have any of these life experiences. And upstream, what is causing so much of that is modern food, modern toxins, and modern stress. And this is where your patience and persistence as a practitioner to help people get at the root causes is essential. I really like using pictures in the realm of patient education. I believe as functional practitioners, we must teach people very specifically what their choices are doing to their body. Thankfully, I believe in many of your communities, you don't struggle as much with patient intake of highly processed and refined foods. They are readily available, but they are expensive. But we have to teach people what is actually in these foods, and even some of the choices that people are making in lower income communities, with things such as highly refined vegetable oils that may be heavily reutilized to the point where they become rancid, which is a serious driver of inflammation meal after meal, or where individuals are choosing conventionally raised foods that are laden with pesticides and herbicides and fungicides, which promote oxidative stress. There are many aspects in our diet that are promoting demands on methylation, and we must teach people to look for these. I also will say that we need to be looking for metabolic dysfunction much, much earlier than conventional diagnosis thresholds for pre-diabetes and type 2 diabetes. I believe this is one of the most urgent opportunities for functional practitioners. We are waiting for this disease dynamic to be entrenched before we diagnose it. And research shows, at least in the US, that insulin resistance has on average been at play for well over a decade before it is diagnosed. And so often we are waiting for metabolic dysfunction to be so advanced that it is causing pancreatic dysfunction, endocrine pancreatic dysfunction. We're seeing an increase in hemoglobin A1C, and then we diagnose it and treat it. But there's a huge opportunity to respond much earlier and be assessing fasting insulin, or even better, fasting C-peptide, to look for a subclinical elevation, indicating that the pancreas is responding to an increased metabolic demand as an adaptive norm. We often see early subclinical indicators of fatty liver way before we see challenges with blood sugar. We see elevated markers of oxidative stress. We see increased adiposity in individuals who are losing muscle mass, and in particular developing increased visceral fat, especially in the torso. But we could be responding even earlier, looking at people's lifestyle. And in this way, we can intervene years in advance and ideally prevent. And certainly I could add to this list right here, COVID, because COVID is a major driver for increased blood sugar simply due to elevated stress hormones, which all on their own, separate from diet, increase blood sugar and oxidative stress. COVID, all on its own, is increasing oxidative stress, all on its own, increasing the incidence of subclinical hypothyroid function, all on its own, impairing nutrient absorption, increasing toxic byproducts from an infectious battle. And so there's an opportunity here to look much earlier to reduce the demand for methylation. If we wait to diagnose this when blood sugar is already elevated, methylation has already been impaired for many, many years. Glutathione deficiency has likely already been at play for many years. We must be looking much earlier. And ideally, we are looking at lifestyle. We are doing thorough intakes. We are looking at people's diet, at their stress levels, at their typical sleep experience, increasingly being able to use wearable devices for loaning these to a patient so that we can get more resilient data in some of these arenas. This is a powerful opportunity for having an impact. Toxins, we must teach people about how unclean water, unclean air, unclean food, personal hygiene products, beauty products, sunscreen, all of these things are contributing dramatically to a toxic burden on the body. Individuals can be more or less vulnerable to a toxin overload based on the aggregate collection of toxins, which usually have negative synergistic effects. Their genetics, yes, and also their diet. And if we don't well biotransform toxins to allow for their ready excretion, then we will retain them in various tissues, the brain, the bones, and in particular adipose tissue. There are many mechanisms of dysfunction and dis-ease in physiology from toxins. And indeed, one of the worst ones is, of course, again, increased oxidative stress, which increases demand on methylation. We can also end up with excessive immune hypervigilance to foods and the environment, which also increases oxidative damage from immune activation. And again, increased adiposity, which over time we know that adipose tissue is endocrine tissue that puts out adipokines that also can wreak oxidative havoc on the body. Increased adiposity on its own, especially visceral adiposity, increases oxidative stress in the body. We obviously could go into hours of detail on any of these topics, but I want to simply raise your awareness of these factors. When you think about toxicity, it's not just a matter of methylation being one of the 6 key phase 2 detoxification processes, but so many modern chemical toxins require multiple phases of detoxification. And when phase 1 and phase 2 are not balanced, we end up converting a lot of toxins to pro-inflammatory mediators that increase inflammation and increase the burden on our endogenous antioxidants like glutathione. And again, more methylation demand. I want to mention briefly the impact of sex hormones. And as I mentioned earlier, the necessity of methylation for metabolism of hormones, in particular estrogens, right? When we generate the hydroxy metabolites of estrogens, they are quite pro-carcinogenic and have strong estrogenic effects. People, not just women, but especially women, men can be vulnerable to this as well, because body fat is endocrine tissue, and body fat makes estrogen, which can wreak havoc with men's androgen balance. But we have to methylate estrogens in order to weaken them so that we don't have excessive estrogenic effects. The challenge is that the enzyme that is promoting that is also needed to metabolize catecholamines. And when your patients are very stressed and they are struggling with higher levels of norepinephrine and epinephrine, stress hormones compete for this substrate along with estrogens. And it's a major driver for estrogenic overload, especially in young people, in young women. Endocrine disrupting chemicals, just giving you a list and some references here to explore. This is a massive issue in our communities, which are potentiating toxic overload and unintended endocrine effects and imbalance. But again, many of these need to be methylated in order to disarm them. Stress, as I mentioned, is a huge factor. And again, so often what people are struggling with in terms of methylation demand or downstream dysfunction in the body is not based on a broken body part. It is a dysregulated body system because a person's life choices, our modern cultural choices, are causing the body to function in a way that gives a life experience that we don't want. And again, I enjoy using pictures to teach patients what is at play. These can be done efficiently, not just in the context of a one-on-one appointment, but in group programs and workshops where you can teach many individuals at once in order to build patient awareness. Our experience clinically in functional medicine is that if you bypass patient education, it is very unlikely that people will sustain habits after their suffering resides. They will stop being compliant. Most people are compliant because they are afraid. And when they start to feel better and they are less afraid, they will be less compliant because they don't actually understand in language that makes sense to them why they should sustain these choices. We must use pictures and simple analogies and stories in order to fuel their commitment, in order to help them to have an aha experience about how their choices are naturally creating their experience. Stress, of course, it can not only be mental, emotional, but physical stress. Things like sleep apnea, things like obesity, excessive exercise, again, exposure to toxins. Many of these are at play in people who will say, I don't feel stressed emotionally, but your body's physiology is really quite stressed. And I would say COVID now is the hallmark of physical stress on the body. And so this poor food, toxin, stress, modern lifestyle choices are a huge aspect of promoting aggressive oxidative stress, and then also immune dysregulation, which is why you're seeing so much immune hypervigilance and increased allergy in your practice, as well as autoimmune disease. Because of this glut of oxidative stress, And ultimately, we must optimize methylation many steps upstream if we want this dynamic to not occur or to recede. I'm not going to talk to these slides very much, but I'm just giving you some background information about oxidative stress and what is causing it. Again, what can we teach people to do? We can teach people to not keep reusing vegetable oil. We can teach people not to char broil foods. Foods that are browned excessively when cooking are basically a meal of free radicals. We can teach people to avoid using plastics, right? We do not want to microwave food in plastic. We do not want to consume highly refined foods. Some of these are simple, everyday choices. But ultimately, we must ensure redox balance if we want people to thrive. Now, I'm giving you here a list of simple everyday lab markers to consider because there are advanced functional labs that can assess oxidative stress. They can be quite expensive and not necessarily available to many patients because of cost, especially if they are not covered by national care. And so I will leave these for you to review. But ultimately, methylation, one of our best readily available gauges for this is homocysteine. Now, I'm not going to cover basic biochemistry on homocysteine. I believe you are well aware. But ultimately, methylation is simply a biochemical cycle where a methyl group is being juggled by various enzymes throughout a cycle. And we focus on methylation and homocysteine being an amino acid of concern. We want the levels to be optimal. And we need methylation for many different processes. We need methylation to make and degrade neurotransmitters. We need methylation to make phosphatidylcholine, which is an essential phospholipid in the cell membrane of every cell in the body. We need it to detoxify, as I've described. But let's not forget that the most important function of methylation is to make epigenetic tags, which control gene expression. Poor methylators have dysregulated genetic activation, which could have myriad downstream biochemical outcomes. And so we must balance these. Now, most of you are aware that methylation depends on key nutrients. We often think about folate as being the celebrity B vitamin for methylation, but vitamin B12 via the enzymes MTR and MTHFR brings folate to the methylation cycle. I would argue that B12 sufficiency is actually even more important than folate. But even above that, vitamin B2, riboflavin, is necessary to activate all of these enzymes. But these are nutrients that are often neglected, and we forget that if we boost one B vitamin, we increase the demand for all of the others. And so today in particular, I want to focus on not only the essential nature of vitamin B2 for activating and enabling these other essential nutrients, but also for enabling transsulfuration. And I want to reframe homocysteine as being not predominantly a toxic threat to the body, but homocysteine is a critical raw material for downstream biochemical processes. It's necessary. And so often when people are struggling with elevated homocysteine, it is perhaps not because there's not enough of the nutrients involved. Certainly that is a common dynamic, but it could be instead because the enzymes that allow these nutrients to be used are being impaired. They might be impaired by inadequate levels of riboflavin, but all of these enzymes are what we call redox sensing enzymes. Methylation itself is impaired with oxidative stress. Methylation is impaired itself when there is elevated oxidative stress, which means you can put all the B vitamins in there you want to. But if we don't deal with the lifestyle choices that are increasing oxidative stress, homocysteine will remain high. There is no getting around the necessity of lifestyle change. When there is an increased demand for glutathione because of COVID, because of an mRNA vaccine that is making lots of spike protein, that is doing a lot of oxidative damage in the body, because of elevated blood sugar, because of toxins, because of stress, when there is increased demand for glutathione, but there's not enough vitamin B6, then of course homocysteine will be high because we are not able to activate the CBS enzyme that requires vitamin B6, not once, but twice in order to make glutathione. So I want to encourage you to start to think about beyond B vitamins, especially beyond B9 and B12. What in a person's life environment that is presenting a lot of oxidative stress might be hampering the activity of the enzymes that drive methylation, even in the context of plentiful, sufficient folate, and perhaps even B12 as well. Now, I also want to there's a reminder here about the importance of gene methylation, which is key for those epigenetic factors that are controlling histone tails that decide whether a gene is actually activated. But in true functional medicine context, beyond the factors that I've mentioned, we must look at individual cases and figure out what is at play in driving impaired methylation. So even beyond the current COVID factors, which add fuel to these challenges, people may have inadequate dietary protein intake. In a vegetarian or vegan population, this can be a real concern. Methionine is necessary for methylation. It is an essential amino acid. The body cannot make it. As I mentioned, we have to have sufficient intake of nutrients. If people are not only well intaking, but also digesting and absorbing folate from fruits and vegetables, this can be a challenge. I've already mentioned the necessity of digestive secretions. Digestive impairment like hypochlorhydria could be a concern. I know that in your communities, type 2 diabetes is a very strong concern. And when there has been endocrine pancreatic dysfunction, where a person's pancreas is not making sufficient insulin, research shows that those individuals are also quite likely to have exocrine pancreatic insufficiency, where you're not producing sufficient digestive enzymes in order to optimally degrade food downstream to enable these nutrients to be well absorbed. We need to be checking serum B12 and red blood cell folate in order to make sure that those nutrients are available. We can look at other markers, not only homocysteine, but things like mean corpuscular volume, where subclinical macrocytic dynamics, where an MCV in the upper half of the normal range may be indicative of suboptimal levels of, say, B9 or B12 that might also be impairing methylation. I mentioned medications can interfere with this because acid reflux is such a common dynamic. Ideally, we prescribe less and less of these acid suppressing drugs because they purposefully break digestion. Instead, we get to the reasons of why do people have acid reflux and help it to actually go away. And even upstream from that, right? What else is at play here in terms of contributing to the dynamics that might precipitate this action? This is where functional medicine really shines at the School of Applied Functional Medicine. This is why we love so much case practice in terms of teaching practitioners how to put together the puzzle pieces for a unique individual. But I do want to say a few more words about transsulfuration, because one of the reasons we find that that patients have elevated homocysteine, that practitioners are neglecting to investigate, is impaired downstream transsulfuration, which, as I already mentioned, is especially dependent on B6. And so homocysteine is a critical raw material for isolating bioavailable cysteine in order to make glutathione. We actually use cysteine also to make taurine, which is an essential amino acid for bile function, individuals who have hepatic biliary congestion, and eventually poor gallbladder emptying that may lead to gallbladder disease, may struggle with inadequate levels of taurine. Again, especially in a vegetarian or vegan diet, this is a concern. We need to be able to readily make taurine in order to have good bile function. And so we realize that, again, even beyond B vitamins, if we want to have optimal levels of glutathione to make sure that methylation enzymes are working optimally, we must carry out transsulfuration. That's not just dependent on homocysteine and B6. We need glycine. I find many practitioners overemphasize cysteine. There's a lot of NAC as a supplement being used in COVID times right now in order to help with oxidative stress. That's an excellent tool, especially if we're worried about impaired transsulfuration. However, if glycine is not sufficient in the context of NAC, then you will not make glutathione. I believe that glycine should always be supplemented coincident with NAC, so we don't end up with just having too much NAC that isn't going anywhere, because we end up with blocked glutathione synthesis if glycine is not adequate. A good reminder that no nutrient works alone. There's some additional information for you here on glutathione and what else might be rate limiting. A particular concern where individuals might be using acetaminophen for pain and inflammation in say, arthritis or headache. Acetaminophen experienced quite a bit additional use during COVID. It was being highly recommended, but this uses up glutathione, right? And so this also is another driver for glutathione insufficiency. But let's talk a bit more about specific nutrients. And again, I'm going to give you quite a bit of information. I won't speak to it all. But we need to remember that nutrients predominantly should come into the body via food. Supplements are not a substitute for food. They cannot be. A food has hundreds and hundreds of ingredients, not just B vitamins, but hundreds of phytonutrients. And phytonutrients affect enzyme activity. Phytonutrients affect genetic expression. If you just keep giving more supplements in the context of a poor diet, it is very likely that people will not experience the relief that you logically would expect, because their diet is at odds with your intervention. There's no getting around the need to boost high quality food as a sustainable lifestyle choice. And so for all of these nutrients, certainly we could talk about supplements, but I also am giving you lots of food ideas, both in the carnivorous diet as well as the vegan diet. Part of the challenge in the world of methylation is that some of the most critical nutrients are not as prevalent in a plant-based diet. They can be, but it requires particular diligence to quality and diversity in a plant-based diet. Now, one of the things I want to speak in particular about, we've already mentioned B vitamins. I'll go into those in detail in a moment. But choline is a really essential nutrient and it is especially plentiful in animal proteins. And so I want to make sure you well understand choline is essential for making phosphatidylcholine, for example. And when we think about demands for methylation, I showed you, and I think you well know, that the intended output of methylation are methyl groups, right? SAMe as a primary methyl donor in the body, what we often call the universal methyl donor. It's delivering these methyl groups to all sorts of different tissues. The synthesis of phosphatidylcholine and also creatine in the body use up more than 80% of the body's SAMe. 80%. And so if we can minimize the body's demand for SAMe in making phosphatidylcholine from scratch, we can minimize the demand on methylation. And this requires choline intake in the diet so that it does not have to be, doesn't have to be synthesized. And so choline is also important in that there is an alternative methylation process called, we call it the choline bypass. This is where we can use choline, dietary choline, to make betaine. And betaine can be used as a methyl donor. So we're not dependent on the B vitamins to methylate. This is especially important in the liver. And of course, this function in the liver is especially key for anyone and everyone who has fatty liver or any stage of diabetes and progressive metabolic dysfunction. I meant to mention this earlier in the diagram. I'll just show it to you. When we're speaking of this bypass, I'm talking about this component of the process, right? Where we can use trimethylglycine, choline, betaine, in order to bypass all of the hubbub with MTHFR and the vulnerable enzymes there. And so this is where the body has other alternatives, not in every tissue, but in some critical tissues like the liver. Now, I am going to give you here several pages on key nutrients, but I want to speak quickly to B vitamins. Generally speaking, we teach and recommend clinically that you only use B vitamins in complex, because as hopefully you already know, or as I've spoken to today, B vitamins are interdependent. We focus way too much on folate and folate supplements in the realm of methylation, and then we're surprised when it doesn't get better, as though the body or methylation is this simple biochemical conversion, and it is not. I believe we need a large measure of humility in the face of this incredibly complex interconnectedness, and that we remember that folate does not act without vitamin B2. Right? B12 does not act without B2 and B3. Homocysteine is not depleted to make glutathione without B6. There are so many interconnected drivers here. We need B7. Biotin is essential for insulin sensitivity in the body to prevent the elevated blood sugar that causes so much oxidative stress that puts high demand on methylation. There are chains of interconnectedness, chains of progressive causality that we must learn to understand through the functional lens. So yes, some people may need a separate high dose B12, for example. But I would recommend that as always, for example, in the context of a B complex as well, so that we are not unknowingly depleting one nutrient by boosting another, and that it is always, always, always in the context of trying to increase the unrefined nutrient density and ideally variety of real food intake. What's going to follow here are just a few slides on B vitamins. There's some nuances in here around the nutrients where they are found in foods, supplement considerations. I believe one of the biggest challenges, and I'll just speak to this briefly, in people taking a B complex that has a high level of vitamin B6, and yet it's not working, is that we are not able to convert the form of B6 in most supplements, which is pyridoxine, into its final usable form, which is pyridoxal 5-phosphate, which requires vitamin B2. It requires riboflavin. It also requires alkaline phosphatase. And you're seeing in your patients subclinically low levels of alkaline phosphatase, right? The bottom quarter or fifth of the normal range. And we cannot use this marker as an objective assessment of hepatic biliary function, for example, when we don't have enough nutrients to make it. And we may have low levels of alkaline phosphatase, in particular, in the context of inadequate zinc or magnesium. Individuals who consume a plant-based diet are much more likely to struggle with inadequate zinc. Individuals who have high stress absorb less zinc. Individuals who've been fighting COVID are highly utilizing zinc. And so we must ensure alkaline phosphatase sufficiency. Non-specific alkaline phosphatase is critical for the conversion of vitamin B6 to its final form, and then also getting it from the blood into the intracellular environment where it can do work. And so just a simple example here of the many different interconnectedness of nutrients that I'm passionate about making sure practitioners understand, because the ability to get a nutrient where it needs to be is more complex than just eating it. The old adage of "you are what you eat" is woefully oversimplified. We are what we eat, digest, absorb, convert to final forms, and get past the cell membrane. We must get into that nuanced detail as opposed to assuming, oh, they swallowed the supplement, they'll be fine. Maybe yes, especially in the day of COVID, maybe not. The oxidative wear and tear on the gut lining, the increased demand for antioxidant function because of COVID is really sending us into a new territory of higher and higher demand for antioxidant function. In terms of vitamin B6, I just mentioned a notable concern there for sufficiency, but I'll mention, and again, there are many considerations here. Some of your patients are using oral estrogen-containing drugs, especially in the realm of contraceptives, or maybe an oral hormone replacement. These are B6 depleting medications. We make the vast majority of the body's serotonin in the enteric nervous system, in the gut. And a bolus of estrogen is not normal in the gut. And estrogen and serotonin have a synergistic relationship. Anytime you're putting excessive levels of estrogen in the gut, you are hyper-stimulating the serotonergic system, which utilizes vitamin B6. And these women can deplete their B6 sufficiency, especially because these medications tend to be used not episodically, of course. They're used for year after year after year as more of a lifestyle medication. And if, as you well seen, if they don't have adequate levels of B6, they cannot make optimal levels of glutathione. You can measure serum glutathione as a high-level marker of sufficiency. Even better, we would be looking at intracellular glutathione. Even more esoteric is the relationship of reduced to oxidized glutathione. But even just checking for serum levels of glutathione, if the levels are subclinically or clinically low in the blood, we certainly can't expect them to be optimal intracellularly. Looking further with regard to nutrients, vitamin B12, I want to just emphasize that B12 must come from a bacteria. Bioavailable B12 is only available from an organism. There are a lot of myths otherwise. A lot of myths otherwise sell all sorts of products. But ultimately, B12 must come from a bacteria, right? From an algae at a minimum, right? And so vegan diets must be supplemented in some way. And there are many reasons why B12 absorption may be impaired, digestion may be impaired, again, because of common medications. And so this is a particular concern. And again, many people, based on their lifestyle choices, may need a separate B12 supplement in addition to a complex, which I believe is really quite safe. But keep in mind that the enzymes that utilize B12 in methylation are impaired by oxidative stress. And there's no getting around that because they're redox sensing. We cannot fake the body into doing otherwise, because when there is a huge wave of oxidative stress, the body goes into a protective survival mode, and it will deprioritize certain functions, whether we or the patient like it or not. And so we must look at our lifestyle choices and how, for example, that might be impairing utilization of B12. You notice I haven't said very much about folate because I think the widespread functional medicine world is talking too much about folate. And we're too focused on it being the celebrity B vitamin as though it is the only issue. And over prescribing folate supplements, we're learning may do more harm than good. Because we're increasing the demand on all of the other synergistic nutrients. And so we want to use great care in starting lower and slower with nutrients. Certainly for older patients, I do recommend making sure you're using a folate supplement other than folic acid, which must be converted in order to have comprehensive effects in the body, and we lose the ability to make that conversion as we age. But it's also key that folic acid is not toxic in and of itself. There are decades of research demonstrating the benefits of folate through supplementation that have used folic acid, because methylfolate has not been widely available until the past couple of decades. But certainly there are medications that impair folate availability. That's absolutely critical as prescribers, that you become very well versed on the nutrient depletions that result from drugs. We tend to be aware of the very alarming ones like methotrexate impairing folate availability, but we don't tend to think of some of the things I've described today, such as proton pump inhibitors, oral estrogen containing contraceptives, or for that matter, non-steroidal anti-inflammatories, ibuprofen, which does erosive damage to the mucosa in the gut and impairs nutrient absorption. It impairs the body's ability to deal with histamine in the gut. So we're more likely to develop enhanced intestinal permeability that is more likely to create downstream autoimmune disease. Acetaminophen, as I mentioned, that uses glutathione for detoxification, puts excessive demand on glutathione sufficiency, especially in the liver. You must learn these so that you're readily thinking about them anytime you prescribe a medication. And so much you can learn about here in terms of nutrient sufficiency. I won't speak to these, but I will mention every time now you think about cysteine or NAC, please remember glycine. I believe they should be supplemented in tandem, because otherwise we're not helping the body to make glutathione. We can supplement with trimethylglycine or betaine in order to get that bypass support. All sorts of examples here that you can use. But again, I want to come back to diet. All of these enzymes that use these nutrients are being stimulated or not by all sorts of lifestyle choices. Dietary intake, vegetables are essential for boosting enzyme function with transcription factors like NRF2. This is where intake of cruciferous vegetables, right? Broccoli, kale, turnips, Brussels sprouts, cauliflower, all of these things are promoting methylation. Allium vegetables, which lovely is at the heart of a good curry, right? Onions and garlic, all of these vegetables, shallots are very helpful for methylation. But we also have to consider that when we're using supplements to boost methylation, we may do that for a period of time, but for maybe the subset of our practices with people who are very aggressively using a huge basket of supplements, we need a certain amount of redox balance in order to stimulate these endogenous pathways.
Hi, Tracy. Sorry for intervening in between, but I was hoping we can take few questions in between.
Sure, definitely. Do you want me to go ahead and speak briefly to the COVID data, or do you want to ask other questions first?
We'll take few questions because people have been asking again and again, and then come on the COVID data. Yeah.
Please.
First, thank you for a very insightful session. All these graphs and pictures, actually, you know, you always get one more pearl when you look at them. Thank you very much. So the question which I'm getting here, Tracy, is what are the clinical signs and symptoms caused by overmethylation with the use of excessive use of supplements? How we bring this balance, and is there any test which can help us prevent overmethylation?
It's a great question. I actually think the easiest way to assess that is measuring homocysteine and looking for when it is too low. It is a key indicator that we may be shunting a lot of the homocysteine down because of oxidative wear and tear. But we're basically spinning the methylation cycle aggressively. And so homocysteine that is below, appreciably below, say, 5, in the US, the typical, as usual, the typical normal range is way too broad, which is evidence, I think, of just how much impaired methylation there is in a normal population. But ideally, you would like homocysteine to be between about, say, 5 and 7. If it gets appreciably down to 4 or 3, I think that is definitely an indicator that there is some hypermethylation. And we want to be supporting that with other antioxidant function. But importantly, looking at the lifestyle and where is this demand for excessive methylation and antioxidant function coming from?
Perfect. This is helpful. And interestingly, you know, I am personally seeing some reports where homocysteine is 3, 4, because a lot of self-medication also happens in this aspect, right? So we have to be careful, right? The another question is, please tell me the connection or relation between HLA B27 and methylation, how it can be correlated.
Yes. So this has to do actually, I think, with genetic methylation, right? And not just specific to this particular gene, but in general, that we must have optimal methylation, very much related to your other question. Actually, let me stop screen sharing for a second here so people can actually see me. We must be able to not overmethylate or undermethylate in order to have good genetic activation. We have all sorts of genetic variants. Whether or not they are activated or not is a question of our overall lifestyle. And again, it's not just the level of methyl groups, which we do need for those epigenetic tags, but all of the other epigenetic factors that lifestyle drives. Toxins affect epigenetics. Dietary phytonutrient composition affects genetic expression. Sleep affects genetic expression. A level of oxygen sufficiency affects genetic expression. There's no getting around the essential nature of health foundations, which is why we teach them so much. And so I'm happy to do a little research. I cannot speak off the top of my head for data in terms of specific patterns for methylation with this particular gene. But I would say overall, we know that people can have alarming genetic variants that are just not active. These people are thriving. And it brings us back to the truth that just because you have a gene does not mean that gene is active and wreaking havoc.
Great, yes. Thank you. So the next question, Tracy, is in such cases, what is the solution in general? That is, what can be done for our kids and what has been practicing and what is being practiced outside? What is the cure rate if we follow the approach?
Are we talking just in general about methylation or cure rate with regard to a specific disease dynamic?
General about methylation, I think, because no disease has been mentioned here.
Okay, I'm very passionate about little ones, and I'm not sure culturally in India if this is as much of a concern. But in the United States, we have somehow adopted the belief that children are not vulnerable to these deficiencies, that because their body parts are newer and fresher, that they can eat whatever they want and they will be fine. And it's heartbreaking as we understand that this is not true at all. And as I mentioned on the slide about the earlier subclinical stages of insulin resistance, the progression of insulin resistance can be accelerated in children, even in very young children. And our feeding of children too much sugar, in the US, there are all sorts of toxic additives and colors and preservatives and flavors that cause oxidative damage. And because kids are not being made to eat healthy whole foods when they're young, they do not develop taste bud tolerance of these foods. I like to teach parents that it is an important aspect of parenting to teach children to try foods many times, and that it's okay if they don't love the food the first time through, but to celebrate that they try the food. Children naturally have more taste buds for sweet flavor because from an evolutionary viewpoint, plants that are sweeter in nature are more likely to be safe. And children don't have as many taste buds for bitter or sour flavors because in the wild, those are more likely to be toxic. But through repetitive exposure, children can learn to tolerate those foods. But if they are being fed a lot of hyper palatable, sweetened, flavored, refined foods as children, they don't develop a tolerance for lots of vegetables, especially not cruciferous vegetables or dark leafy greens. And so childhood in the US includes a huge amount of crap food, lots of calories, lots of chemicals, but woefully low levels of phytonutrients. And I think we address this by introducing healthy foods early on. We need to get rid of the concept of a kid diet or a child's menu. That's ridiculous to me because this is a modern development. For the vast majority of human development, children ate the exact same food after nursing that children did. It's just the food was cooked more and mashed up, but children had to chew. They had to learn to palate foods. And I think we must return to that as a cultural norm.
Great. So the next question we have, Tracy, is can you suggest some supplements for methylation process, which we've already done, or natural diet? So anything you would want to speak on diet for methylation?
I do think that just simply boosting intake of vegetables I think, at least here in the States, and this may or may not be a concern, and I'm sure it varies by community for you in India. Unfortunately, the American diet has spread. This is not a good thing at all. But we are consuming way too many refined carbohydrates,
Right.
way too many refined grain products. And pulses are wonderful. Vegetables are wonderful. We're consuming too many sugars, too many fruit juices, and too many refined carbohydrates. Likely in the context of our toxic environment, people who are sedentary are consuming too many carbohydrates, period. And so more vegetables, which bring more fiber into the diet for a lower glycemic load, and in particular cruciferous vegetables and allium vegetables to promote that NRF2 function, as well as bringing lots of bioavailable folate.
Great. So the next question we have is your inputs on raised and low methionine. What's the significance of both? Any relationship with histodelia and histopenia? And anything you want to say about how do we manage these situations?
It's a great question. Excuse me just a second. Pardon me.
No worries. Thank you.
There's no getting around the necessity of methionine. And this is a fundamental issue in a fully plant-based diet. And being able to share with patients who are following a strict plant-based diet, or even a vegetarian diet, it's a terrible combination to follow a vegetarian diet and be lactose intolerant. And the majority of the world's population is lactose intolerant. I actually believe that many people's natural state of bowel transit is one of constipation, but they're consuming dairy foods and they have some degree of lactose intolerance. And so their natural state of constipation is being masked with rapid transit time because of lactose maldigestion. And so dairy foods are not necessarily the solution for those individuals because they are promoting nutrient malabsorption because of the rapid transit time. And so methionine can be supplemented with, right? A good protein mix may be a very important supplement in people who have dietary choices or inadequacy in the diet, but there's no getting around the essential nature of that to drive methylation. And so I think it's a key consideration. There's definitely a concern with the other downstream dynamics with over and under methylation. This also affects how we handle histamine because histamine regulation depends on methylation. We could get into some of the details there. There are some references in here that I think will be of value for follow-on for that question. But we must be looking at methionine, and we can measure methionine in blood and see where are the levels. That's an easy place to begin.
Yeah, perfect. Thank you. So the next question is, what is the effect of glyphosate on methylation and transsulfuration pathways?
Great question. So glyphosate directly interferes with the function of methylation enzymes, but the bigger issue is it interferes with glycine function, and this impairs glutathione. This is a huge problem. And so some people are more vulnerable to this. I'm not sure of the status in India. This is a massive problem in the US because of widespread use of glyphosate.
Huge problem in India also, Tracy. In fact, a lot of diabetes can be, traced back to use of glyphosate.
Yes. Yes. Very much so. And this is a widespread problem in our water supply, which is one reason why I think water filtration is so important, because it's a dissolved toxin that is not necessarily fully filtered out by our municipal water systems. And so it's a ubiquitous toxin for sure. And obviously, Here in the US, organic standards would be your best avoidance for glyphosate, but it does point out again the importance of glycine supplementation where glutathione function is inadequate, and the importance of getting glycine in there with NAC, so that we're better assured that we're getting glutathione. Or in your cases of, you know, acute oxidative stress or really debilitating long COVID, using overt glutathione for a few months, I think is an excellent solution, because we don't want to speculate that any of these enzymes are working well, because they may not be. A person may be stuck with a systemic enzyme dysfunction.
Perfect. So Tracy, Nitya wants to know, you mentioned that taurine is hard to come by in a vegan and vegetarian diet. What's a good source of taurine in a veg diet?
What is a good source of taurine in a diet? Let me include a slide on taurine in the slide deck. I will add one so that that can actually be included for reference.
Perfect.
I think that's probably the best, because then you can make a list, right?
Yeah.
But keep in mind that taurine is something that we are intended to synthesize, right? We are intended to be dependent on that to some degree, especially from an evolutionary viewpoint during times of long fasting, like in the cold months. But that does depend on the transsulfuration.
Perfect. So Anu wants to know, is IV NAC effective in those with lactose intolerance?
Is IV NAC effective for those with lactose intolerance? For stopping the lactose intolerance?
Yeah, or maybe giving them relief from the symptoms.
I would actually say, what I would recommend is, if a person is lactose intolerant, they shouldn't be consuming dairy foods.
Right.
I think we have to stop trying to outwit the body's natural state of wellness. If you think about it, there's nothing particularly natural about consuming a reproductive infant food for another species specifically. And if it's well tolerated, that's wonderful. But as I said earlier, I think it is masking a lot of constipation that would help us to find a lot more, for example, subclinical hypothyroid function that's not being treated because bowel movements are perfect because of lactose intolerance, and women are suffering from this thyroid function that we're not finding because we're masking it. I don't think it's best to try and outwit the body with lactose intolerance. I think we simply need to avoid lactose. I'm concerned about the rapid transit time and the malabsorption that drives, because that could be at play for all sorts of nutrient deficiency, not just things that affect specifically methylation. Now, or is there more lactose intolerance because of poor methylation of genes? Absolutely, I am sure. But that is not, that's not just about NAC, right? That's about ensuring overall adequate methylation.
And I really liked what you said about hypothyroidism, Tracy, because we see it very commonly, but a lot of people are not aware about that. Right? So the next question we have is, Dr. Kalpana is saying, can you please summarize about the nutrients regarding the complementary need of each vitamin? For example, B2 is required for B12 absorption.
Okay, I'm sorry, just say that one more time.
Can you please summarize about the nutrients regarding the complementary need of each vitamin? For example, B2 is required for B12 absorption.
Yes. So let me take a step back, right? So from an enzyme activation, so B2 is required for activation of the MTHFR enzyme in order to use folate and methylation.
Right.
Both B2 and B3, as NAD and FAD, are required to actually recycle B12 in the methylation process. The MTHFR enzyme uses B2 and B3, And this is how we remethylate cobalamin to become methylcobalamin in order to use folate and methylation. We need B2 to convert B6 to final forms to use it in some of these enzymes. There are many examples. B2 is essential in mitochondria for just cellular respiration. This is why I say we have to be cautious about oversimplifying that only one gene or one enzyme is involved. The richness of what is involved here is dramatic. If there's inadequate B vitamins to support the Krebs cycle, right, the citric acid cycle to generate ATP, we are more likely to have excessive oxidative stress in the mitochondria, which further increases demand on glutathione. There's tremendous interconnectedness here, and B vitamins are really essential for this.
Perfect. So Dr. Kannan wants to know, can high ESR reflect B complex deficiency associated with pernicious anemia?
I would say yes. I think ESR is a good, it's an often neglected marker of inflammation. Here in the US, we have tended to focus more on high sensitivity C-reactive protein,
right,
which is a particularly cardiovascular mediated marker. It's also quite labile. And so CRP will normalize or become optimal when there's still notable inflammation in the body. And so I recommend the use of, say, ESR, where there are more endogenous drivers for inflammation, like oxidative stress, or things like ferritin, elevated ferritin, where the body has begun to sequester iron in the face of an infection, which, by the way, I know iron deficiency anemia is very common in your populations. Sometimes people have suboptimal hemoglobin and serum iron, but it is not because of iron deficiency. It is because of iron sequestration. And ferritin will be subclinically elevated, while hemoglobin and serum iron may be subclinically low or even overtly deficient. And these people do not need more iron. In fact, the body is already alarmed at iron, which is why it is sequestering it. And so what it needs is for you to address the other source of inflammation. Where is the infection? Where is the toxin? And seeing ferritin actually come down is a good marked objective indicator that the body is convinced that the source of inflammation has resolved. But I do think ESR is a good one, less labile than CRP, but probably a bit more labile than ferritin.
Right. So Malay wants to know, does dietary NAD plus regulate methylation, and what should be the ideal daily dosage?
I don't know the dosages off the top of my head per se. I do think NAD, especially in the context of COVID, can be a really valuable supplement because of the impact of COVID on mitochondrial dysfunction, which I think is the pathway for an awful lot of long COVID symptoms. Because mitochondria are especially dense in neural tissue. And so where we see people with brain fog and cognitive impairment and fatigue and memory loss, we need to be looking at the integrity of nervous tissue. And this is where things like B12 sufficiency for myelin integrity or CoQ10 for healthy cell membranes is key. But NAD overtly supports cellular respiration in the mitochondria, absolutely key for repair internal to the mitochondria. I'm pretty sure there's some dosage information on NAD in the slides that I've included, but I will double check and be sure of that when I send over my final slides for you to share, Priti.
Perfect, Tracy. Tracy, so Simriti wants to know, which are the key supplements for someone with high homocysteine, especially if the person is tight on the budget?
I really think that if you're going to recommend one supplement for high homocysteine, now I could be cheeky and say better diet, right? Which is already part of the home budget. But an actual overt supplement, I do think it's a B complex. And I would say a B complex with bioavailable B6. I think it is better to choose a B complex with at least a significant amount, at least 50% of pyridoxal 5-phosphate, so that it can be used right away. I think if you're going to choose one, that would be one to choose for sure.
Okay.
I think if there were to be a second one, I actually think it would be choline, which is going to surprise many of your viewers.
Yes.
But choline can be so deficient in a plant-based diet, or even, alluding back to the prior question, right? Taurine, a vegetarian diet, it's got to come from the dairy. Well, if people aren't choosing the dairy, there is no taurine. You have to make it. So these are just important considerations downstream. But I do think those are what I would emphasize.
Perfect. So the next question is, please explain the role of DNA methylation in aging and link between NMN and methylation.
That is a very involved question. I'm not sure I'm going to be able to say anything useful off the top of my head.
Perfect. I understand that, Tracy. So we can move on to the next question.
Well, let me just say briefly, right? I mean, NMN is important because of NAD, and it alludes to the same question before, right? So we need NMN to make FAD to drive cellular respiration. I think it very much is in line with the prior question. But I will see if I can find a good reference for you for that.
Which methylating agents are effective in high reverse T3 levels and symptoms of hypothyroidism, cervical spondylitis, and CTS?
So first of all, I would remember that reverse T3 is normal. That is how the body handles balancing optimal thyroid function, so that intracellular basal metabolic rate is neither too high nor too low. And reverse T3 can be high because people are making too much T4, people are taking too much T4 in a drug. But when reverse T3 is elevated, it may be because the body is not able to make adequate T3. It's not affecting good T4 to T3 conversion. And the biggest reason that happens is stress. And of course, oxidative stress is right at the top of that list. Whenever stress hormones like cortisol or norepinephrine are elevated, this naturally impairs T4 to T3 conversion. It restricts the activity of the deiodinase enzyme intracellularly.
Yes.
And so you're going to see higher levels of reverse T3. It is also part of the body naturally putting on the brakes, because the body does not want to have a lot of extra oxidative stress from normal metabolic functioning when there's already a lot of oxidative stress. Which is a reminder that the body is not interested in people being lean and losing weight and having a fast metabolism when there's a lot of oxidative stress, because that would promote disease and death. So again, we have to go upstream and get at the roots. So for me, elevated reverse T3, in the context, especially of suboptimal free T3, is a sign that we need to go upstream and find the stress, which very often is physiological, in order to convince the body that it is safe to have a higher basal metabolic rate. It will not promote organ failure, for example.
Great. And this is a very important question, because I think hypothyroidism is another thing, and raised T3 is something which we were never measuring before, but now more and more we are measuring and we are realizing the importance of it.
Yes, absolutely.
So Dinah has a question: how to correct methylation process on excessive uric acid, and how to start including vegetable, and what kind of best vegetables and other choice diet in excessive uric acid cases.
Okay. So uric acid, we associate your elevated levels of uric acid with different disease states like type 2 diabetes. And we need to remember that uric acid is a very potent antioxidant. Ideal levels are not rock bottom. In the blood in particular, uric acid is a very effective antioxidant. But when there is excessive oxidative stress, it naturally promotes the synthesis of more uric acid as a protective response. And so indeed, we want to get at the roots. We would like to get at the roots of type 2 diabetes and reverse it, which functional medicine is very capable of. The enzyme that is at play in making the excessive uric acid is an enzyme called xanthine oxidase. This can generate a lot of free radicals. And in fact, the common medications that are prescribed for gout interfere with this enzyme. I think one of the best nutrient supplements for this are flavonoids. And things like quercetin or luteolin can be very effective for this. And there are great supplements that mix different flavonoids together to counter high uric acid. But quercetin taken, I would say 1,000 to 1,500 milligrams a day in divided doses could be quite helpful for actually just slowing the enzyme that's making the uric acid. But again, we have to go upstream and address, why is the body in its wisdom making more uric acid on purpose as a protective mechanism?
So Tracy, what you said, this time the IFM newsletter, I have published a report wherein a patient on steroids and high uric acid came to me, and the only thing I did was put him on elimination diet for 1 month. His uric acid came down to normal, his steroids went off, his medicines went off in a period of 1 month.
Wonderful.
Right. So when you said cause, why is the body doing it? You're troubling your body and the body is not liking this, and then you keep putting bandages over it at all places. That doesn't work, especially when we work with functional medicine approach.
Exactly. And let me say a word quickly about elimination diet as well, because it's such a wonderful tool and the patient gets very educated experientially through how their diet affects them. But for a long time, we've known that different medications can promote enhanced intestinal permeability, that will promote food sensitivities and contribute to this systemic inflammation. But COVID has worsened this dynamic dramatically. Steroids create leaky gut. All by themselves. And so I love the wisdom of looking, as the saying goes, when you hear galloping hoofs, don't think zebras, think horses. Look for the obvious drivers in the context of this patient. They're taking a steroid medication. Of course, they have food sensitivities. Of course, their uric acid is high. We have to look for the upstream drivers. Good for you. That's wonderful. I appreciate you sharing the case wisdom.
Thank you. So last question before we can come to your COVID slides, Tracy, is can poor mitochondrial function or poor metabolism cause hypothyroidism? Hypo, not necessary, also means thyroid pathology. So I will reread the question. Can poor mitochondrial function or poor metabolism affect thyroid pathology?
Yes, in a synergistic way. I think we are increasingly learning that often some of the first drivers for insulin resistance or metabolic dysfunction come from subclinical hypothyroidism in the liver. And that may be the beginning of the liver's poor fatty acid oxidation. And this is why very often some degree of steatosis is first. And then we end up with problems with blood sugar. And then we end up with type 2 diabetes. And so, as I mentioned earlier, in the context of the reverse T3, any persistent inflammatory dynamic is going to impair T4 to T3 conversion on purpose.
Right.
And so this is where there's a chicken and egg dynamic, right? Which came first? The hypothyroidism exacerbates the insulin resistance, exacerbates the hypothyroidism, exacerbates the insulin resistance. And we have this synergistic forward feeding metabolic function, I think because of both. And so to your point, there may not be actual thyroid pathology. The
Yes.
thyroid itself may be fine. There may be no goiter. There may be no autoimmune. T4 synthesis is fine. But all of the peripheral T4 to T3 conversion that is happening intracellularly throughout the body is purposefully being downregulated because of localized restriction in order to allow healing. And again, lifestyle choices are everything in terms of what is promoting that upstream.
Perfect. Tracy, we can come back to your COVID slides. If you can quickly do that. We have already exceeded our time by 40 minutes though. So I leave that choice to you.
Okay, I do just want to speak briefly to the slides. I have a lot of references because obviously quite a bit of this information is hot off the presses for all of us. We're busily studying it, trying to learn what we can. And so certainly the science is a long way from comprehensive in this particular realm. But let's see here. But I just want to share that I think the time for the rise of functional medicine has never been more urgent and more pertinent than it is right now. The question comes up all the time in our practitioner community and is daily discussed on our practitioner forum at SAFM. You know, what is at play in long COVID? And I think we well understand now what's at play in long COVID. And we have to look for and characterize the specific functional imbalances and disease dynamics that are at play in specific individuals. And these are the ones that we are seeing most often, for sure, and very pertinent for our conversation today. The redox imbalance is definitely the most common one because it is contributing to mitochondrial dysfunction and neural dysfunction, right? And so many people are benefiting from a B complex, some ubiquinol, right? The reduced form of CoQ10, maybe some overt glutathione support in order to do more direct intervention to counter the oxidative damage and allow the nervous system to heal. Because, as I mentioned earlier, all of the ACE2 receptors in the gut, we are seeing more nutrient malabsorption, and we're seeing more loss of barrier function in the gut. I think, unfortunately, we're only seeing the very beginning of the massive wave of autoimmune disease that is to come on the other side of COVID because of that loss of barrier function in the gut, which is creating systemic inflammation and molecular mimicry that promotes autoimmune disease. And also because there are multiple epitopes available for SARS-CoV-2, but also for spike protein just coming from vaccinations that are promoting of autoimmune activity. And I'm especially alarmed about the magnitude of that I think we're going to see in terms of autoimmune thyroid disease.
Yes.
So several dynamics here. These are 3 articles that I think are especially valuable, but I want to give your practitioners some specific assessments to look at in these individuals, right? I'm very concerned about B12 status, specifically in long haul COVID patients, because of its absolute necessity for healing the myelin sheath. We think about B12 doesn't actually have that many separate functions in the body. It's essential for methylation, which downstream affects a lot of things. But B12 is critical overtly for the integrity of the myelin sheath, which I think is being heavily damaged in COVID. Glutathione sufficiency we discussed. Tryptophan is a big issue because we know that serotonin synthesis is not the normal dominant tryptophan metabolic pathway. That's the kynurenine pathway, which becomes co-opted and enhanced during infectious disease, especially viral disease. This leaves less tryptophan available for serotonin. And when people have suboptimal serotonin function, they experience more anxiety. They experience enhanced pain perception. They experience gastrointestinal dysmotility. So we want to be looking for, you can be measuring tryptophan in blood. You could be looking at tryptophan kynurenine ratios. But the other double whammy for tryptophan is that in the gut, the ACE2 receptors are part of chaperone function for tryptophan absorption. So the downstream impact of COVID is not only more tryptophan shunted away from serotonin, but poor tryptophan absorption in the gut. And if we don't have optimal serotonin function, then we don't have optimal melatonin synthesis. And we need melatonin for antioxidant function as well as for sleep. This is at play in more people in your practice than you may realize. Autoimmune activity, we could talk for an entire day, Priti, about this and all of the molecular mimicry. We just need to be looking for it. If you see signs of a certain autoimmune dynamic, test for it, because I think it's creeping up. Thyroid function is going to be more of a concern in COVID because of the inflammatory dynamics we were discussing earlier. So there are thousands of papers out there in the realm of COVID. We've read an awful lot of them. These are some references, and I'm just giving you in the footer the hyperlinks for the ones that I am showing in the visual. They're not separate. It's just the hyperlink for ease of going to the full text. But this is just about a dozen of them that I hope will be of particular use for further learning for your practitioners, because we must become proficient at assessing these dynamics. But before we go, I do want to share this with you. I think you're aware. We want to appreciate your participants, your practitioners, by giving away some tuition-free admission to our next advanced practice workshop. I really want to say thank you to all of your practitioners, and everyone who registered for this session will be automatically entered into a drawing to attend an advanced practice workshop. Our next one is on November 5th. These are live interactive workshops, or you can access the archive later on if you cannot attend. But I just want to say thank you to all of your practitioners for taking time to study, time to learn, time to advance their clinical toolbox, especially in these really unprecedented times. I think especially in our lifetimes, for the progression of disease that is very methylation dependent, if we are to arrest their progression and then promote their regression.
Thank you, Tracy,
thank you
for
so much.
this great offer. Thank you for being here. The session was very, very, very informative and enlightening. I'm sure everybody who joined is going back with a lot of things to do tomorrow morning. Right, for the patients, some of them were thinking I'm giving NAC, but I think glycine is missing, and someone was thinking B12 is being given, but B2, B3 is missing. So I'm sure everybody has their own notes. It was a pleasure to have you here, and I will wait for this PPT from your end, and will circulate with all the participants. Thank you very much. And on a personal note, your passion is so visible, so infectious, and it was lovely to listen to you for the last how much? Almost 2 hours now. Thank you very much.
You are very welcome. Thank you for your keen questioning and for your leadership in this community and driving the awareness of functional medicine forward. I appreciate what you do in spreading the good word around the world. Thank you so much.
Thank you and bye-bye. Have a great day.
You too. Bye-bye.
Thanks. Thank you everybody for joining us. If you have any questions, do send it to me and I'll share it with Tracy. Thank you guys. Thank you very much. Special thanks to Dr. Musa. Thank you, Dr. Musa.
Thank you very much. So we are ending the session. Thank you very much, everybody. Especially thanks to Tracy. Very
thank you.
very good session.
Oh, excellent.
Okay, take care. Bye-bye, everyone.